Bismillahirrahmanirrahim. Today we are going to discuss about two important diseases of the large intestine, and these are the hemorrhoids, commonly known as piles, and the other disease that we will discuss is the diverticulosis. Formation of outpouchings or sacs in the large intestine, particularly in the sigmoid colon. The two diseases are entirely different. The hemorrhoids is a vascular disease of the intestine, while the diverticulosis or formation of diverticula is the disease in which the large intestine at the weakened points are outpouched, forming sac-like structures. Before we go to discuss hemorrhoids, we must have a knowledge of the normal rectum and anal canal. The hemorrhoidal plexuses, these are the normal anatomical structures which are located within the anal canal. If these plexuses are enlarged, they can protrude outside the anal canal, causing symptoms. Hemorrhoidal plexuses are essentially the veins, the rectal veins forming plexuses. The Pectinate line, also known as dentate line, is a line which divides the upper two-thirds and lower one-third of the anal canal. The Pectinate line marks the division between the anal canal and the rectum. The Pectinate line actually marks the area supplied by the visceral and peripheral nervous system. Embryologically, anything above the pectinate line is of endodermal origin. We know that the whole body organs are derived from the three germ layers, the ectoderm, endoderm, and the mesoderm. Structures below the pectinate line, they are of ectodermal origin. By that we mean that they are related to the structures that are derived from the ectoderm, which also give rise to the skin. The region above the pectinate line, the endodermal region, is essentially a part of the abdominal organs, and therefore any pain in this area will be diffused and not localized. While the region below the pectinate line is considered as a part of the skin, and this area will be very sensitive to pain, and lesions in this region are actually very sensitive and very painful. There are muscles surrounding the anal canal. The external anal sphincter, this is a muscle and it is a voluntary muscle which surrounds and adheres to the anus at the lower margin of the anal canal. Normally, this muscle is in a state of tonic contraction, but during defecation it relaxes to allow the feces to be released. The internal anal sphincter, this is totally involuntary. And the other important muscle here in the anal canal and rectum is the levator ani muscle, which form the floor, pelvic floor. Hemorrhoids are actually the enlarged tortuous dilated veins in the internal hemorrhoids or external hemorrhoid plexuses. So hemorrhoids may be internal or they may be internal. When they are above the pectinate line, we say these as internal hemorrhoids. And if they are below the pectinate line, we say these as external hemorrhoids. Actually, the hemorrhoids are thin-walled, submucosal, dilated veins in the anal and perianal regions. And here one thing appointed that I want to mention, that the anal canal and this region is drained by the rectal vein, superior rectal vein, inferior rectal vein, and middle rectal vein. The superior rectal vein, actually it joins the portal vein, and the blood drained by the superior rectal vein enters into the portal circulation. While branches of the middle and inferior rectal vein, they join the systemic circulation or venous circulation or caval circulation. And here anastomosis exists between the internal and external hemorrhoid plexuses. So whenever the pressure, for example, in portal hypertension, if the pressure arises in the portal circulation or in the portal vein, what will happen, that the blood in the portal circulation, it will backflow through these anastomosis to find its way into the caval or systemic circulation. So when these anastomotic channels become tortuous, dilated, they will form hemorrhoids. So hemorrhoids may be formed in the internal hemorrhoidal plexus called internal hemorrhoids, or they may be formed in the external hemorrhoidal plexus called the external hemorrhoids. Mostly the pressure that will cause backflow of blood from the portal circulation into the caval circulation and into the anastomosis that exists between superior rectal vein, inferior rectal vein, and middle rectal vein. So its causes can be severe and prolonged constipation. Pregnancy can pressurize the veins and cause the backflow of blood from the portal into the caval circulation, or in opposite direction. Obesity may be a cause. Weightlifting, usually in gyms and exercise, it may cause pressure on the veins and the blood may flow in upward direction. Portal hypertension is a very important cause that causes the backflow of blood from the portal into the caval circulation. And in addition to the hemorrhoidal plexus, the two other important points are the esophageal varices and the anastomosis that occur at the umbilical region. So the esophageal region or esophageal varices, the umbilical region where there is anastomosis between the caval and portal circulation, and the hemorrhoidal plexuses. These three are important points, and out of the three, the esophageal varices are very dangerous, which may occur in cases of liver diseases and portal cirrhosis, and may cause serious complications. In the hemorrhoidal plexuses, the backflow will cause either internal hemorrhoids, which are usually painless and are not so much of concern to the patient. But the external hemorrhoids, since they are supplied by the sensory nerves uh, uh, and they belong to the tissue of ectodermal origin like skin, so they are very painful and very problematic for the patient, particularly if the external hemorrhoids, if they become thrombosed. So hemorrhoids are thin-walled, dilated, submucosal, perianal, and anal vessels. The internal hemorrhoids are further divided into 4 degrees. In the first degree internal hemorrhoid, the hemorrhoid lies inside the anal canal. In the second degree, the hemorrhoid may come out during defecation, but it reduces itself when there is no pressure or straining. The third degree hemorrhoids, they collapse and come out of the anal canal, but they can be reduced by using a finger by the patient. While the fourth degree internal hemorrhoids uh, make the severe and serious case in which the hemorrhoids that protrudes out the anal canal cannot be reduced. The internal hemorrhoids are usually painless, and sometimes the patient may complain of erectile fullness or discomfort, and sometimes they may be associated with a mucus discharge. In contrast, the external hemorrhoids are very painful, and there can be severe perianal pain and filling up a perianal mass. This type of pain becomes very severe on defecation, and particularly if thrombosis occur in the external hemorrhoids. Now coming to our second topic, uh, that is included in the inflammatory intestinal diseases. So the inflammatory intestinal diseases uh, are those diseases in which there is an associated inflammation in the large intestine. The Sigmoid diverticulitis is the disease in which uh, the diverticula are formed inside the large intestine, particularly in the sigmoid colon. And if these diverticula becomes infected, this we say, and if there is inflammation in these diverticula, we call them as the diverticulitis, and in case of sigmoid colon, we call them as the sigmoid diverticulitis. The two other important diseases are the Crohn disease, also known as renal enteritis, and ulcerative colitis. We will discuss them later on in detail. And there is an intermediate colitis which cannot be differentiated either as Crohn disease or ulcerative colitis. So, what is diverticulosis and what is a diverticulum? Diverticulum is actually a small outpouching between the tinea coli. We know that the intestine is composed of different layers, and starting from the inside there is mucosa, which consists of epithelial cells and lamina propria and muscularis mucosa. Then there is submucosa, which contains connective tissue, blood vessels, and lymphatics are located in it. And the muscle layers, which consist of an inner circular and outer longitudinal layer. And the outermost is the serosal layer, which is formed by the peritoneum. But in the large intestine, what happens that the longitudinal muscle fibers, they get together and are gathered, forming 3 lines which are known as the tinea coli. So the diverticulum is formed usually due to increased intraluminal pressure, which may cause an outpouching of the intestinal wall. If the whole wall of the intestine is outpouched and if it forms a sac, this is called the true diverticulum. But mostly the mucosa and submucosa protrudes in between the tinea coli because the longitudinal muscle layer is not continuous in the large intestine, but it is the longitudinal muscle fibers gathered together to form the tinea coli, which are 3 lines that run along the large intestine, and their contractions will cause hastrations in the large intestine to push the fecal matter forward towards the rectum. So the two important points that determine the formation of diverticula is the increased and high intraluminal pressure in the large intestine and the weakened portions in between the tinea coli. And here we will particularly discuss the blood vessels, the nerves and their sheaths that enter through the circular muscle layer to enter into the large intestinal wall. So the area of the circular muscle, smooth muscle cells, where the tinea coli of the longitudinal muscles are not present, and particularly in those regions where the vessels and nerves and their sheaths enter into the intestine, they are the weak points. And the high intraluminal pressure will push the mucosa and submucosa, forming the diverticula. So actually the diverticula are acquired form of pseudo-sacs or pseudo-diverticular outpouchings in the colon. This type of diverticula and diverticulosis most commonly occur in aged people. And since the sigmoid colon in the large intestine is comparatively the narrower region, so they are most common in the sigmoid colon. As I mentioned that the increased intraluminal pressure and the weakened portions in the wall of the intestine, particularly where the blood vessels, nerves and their sheaths enter through the circular muscle layer as the in between the tinea coli, which are consist of longitudinal muscle layers. So these weak points, they form the sites where the intraluminal pressure will push the mucosa and submucosa into a to form an outpouching or sac or a diverticulum. Mostly these diverticula, they are sites where the stool can become impacted, and these are the sites where bacteria can colonize and populate and result in inflammatory conditions called the diverticulitis. Here in this picture, there is a cross section showing the outpouching of the mucosa and submucosa beneath the muscularis mucosa. Histologically, this microscopic picture shows protrusion of the mucosa and submucosa through the muscularis mucosa. The diverticulosis is mostly asymptomatic, and most of the time the patient is unaware of uh, unaware of the fact that they have a disease. But if we do colonoscopy or other investigations for some other uh, reasons and for some other diseases, we may incidentally see the diverticula. The diagnosis of the diverticulosis in large intestinal diverticula uh, can be made by the colonoscopy, computer tomography, and sometimes the barium enema, in which a contrast dye is given to the patient rectally, and then x-rays are taken that will outline the diverticula if they are present there. The complications of diverticulosis are that most of the time they do not produce symptoms and the patient is asymptomatic. But if fecal matter is impacted, or if there is infection, bacterial colonization, or inflammation of a diverticulum or more diverticula, this will result in diverticulitis. And this diverticulitis can be sometimes uh, very problematic, and it can give rise to complications. Particularly if the intraluminal pressure rises, the diverticulum can get perforated. And if it perforates, it may form a pericolonic abscess. Sometimes, if the intestinal contents are the bacteria, they are released into the peritoneum, it may cause peritonitis. And sometimes, the perforation in a diverticulum will make its way into the other organ. It may form the sinus tracts. For example, if it makes its way into the urinary bladder, it will form a colovesicular fistula. And in what case the fecal matter and intestinal contents, they may uh, go in to be passed in the urine. The repeated happening of the diverticulitis may sometimes cause segmental colitis. And since here the chronic inflammation is involved, and we know that in chronic inflammation, scar tissue formation and fibrotic thickening will occur, so there can be fibrotic thickening in and around the colonic wall. And this may lead to the formation of strictures which in occasions may cause intestinal obstruction. Since the blood vessels in a diverticulum, which is formed of a thin membrane only covered by the serosa of the peritoneum, and there are no longitudinal muscles present here, so these blood vessels are very prone to the injury. And if they become injured, they may result in bleeding into the intestinal lumen, and the blood may be passed in the stools, causing the melena. Thank you very much.